like they were being interviewed by the police. They felt interrogated, and they would feel that they would be or might be blamed for it and would clam up. And as a result, we would get a report that told us what we knew already and recommendations that we could have said about what went wrong, not really getting to the heart of actually how can we learn and then improve upon this. So following feedback from staff, and interesting that Bill said about teams. Well, incidents don't occur in isolation, they occur in teams. So I started a process of multidisciplinary team reviewing the incidents. And language is also important, so flipped it from investigation to reviewing and brought in an external person as a member of that multidisciplinary review panel. And it just changed things. So we never had a one-to-one interview. They would have the team in focus groups, and people felt more comfortable to then talk about what really happened and learn from it. And then the leadership of the team, so the consultant and the ward manager, would also be interviewed together. As a result, we had a different real value in the report that came out, and the team actually made the recommendations and owned the action plan, and also brought in the family of and the patients into it. So everything became more of an opportunity to learn and improve and really make sure that those incidents don't occur. And for me, from that perspective, it just changed the whole culture. It didn't happen overnight, but as a result, people felt more comfortable and more able to report things and errors, and gave them the headspace to really learn and improve things.
Are there cases where you feel that perhaps patients prefer to have an external investigation?
Well, absolutely, I'm sure, because again, it's that bit about that things are hidden, but it's a process by when you explain that, you know, it's about learning, and actually you have a better understanding when you have the whole team involved in it rather than one person who doesn't understand how it works. And, you know, healthcare is complex. And though you might train for different scenarios, you can never train for that specific scenario of that person in front of you. So it's important for us to understand, you know, from different perspectives and different professionals, actually, how can things be improved? And it's also about the processes that, I suppose, as a trust, we've put in place or not put in place to ensure that we create an environment that is safe.
Okay, thank you. Phil, what's the most valuable lesson you've had from your leadership experience at the Fire and Rescue Service, which might be useful to NHS leaders?
I suppose it's reasonably obvious from a Fire and Rescue Service point of view about courage. And I talk to my firefighters regularly about, you know, being courageous, but actually I don't necessarily talk about it in the obvious. So, you know, members of the audience might think that Fire and Rescue Service is a very brave and courageous service and to the public, and when we do, we go into burning buildings and we rescue people. But that's not the courage that I'm talking about, actually. It's the courage to act, and the courage to maybe raise a question in an environment such as this, to have a view, to express that view, for fear of maybe making yourself look a bit foolish at times, or to call something out in the workplace when it's clearly unacceptable. And that's the courage we look to develop, but based on the brand of the Fire and Rescue Service. So we developed a set of values, really. There's only 3. They're very simple, and courage being one of them. But that really twofold: one, the courageous acts that we do for the public, but courageous internally in regards to improving the service and calling some stuff out if we don't see it, or, you know, or looking for that kind of continuous improvement. Compassion, and again, very similar value, really, that we describe. The compassion that we show to the public, and putting the public of Merseyside particularly at the heart of everything we do, and the community of Merseyside come first, absolutely, you know, fundamentally. But also the compassion we show towards each other about, you know, how we interact, the sensitivities we show, the care we show, the kindness we show, all things that you might not necessarily think about from a fire and rescue service point of view, but they're incredibly important that we demonstrate that care to ourselves as much as we do to the public. And then integrity, and you kind of go back to some of the things that colleagues have said on the panel, really, about doing the right thing and being clear about expectations and standards of behaviour that we accept of each other or we expect of each other, and about making sure that people are clear on some of those things. I think it's pretty fundamental, to be fair, because it gives people reassurance. But then again, I go back to some of the kind of comments previously about creating a space to listen. And listening's important, but what I would say is hearing's more important. Because sometimes people sit and they listen. They don't necessarily hear. And I think you've got to work harder to hear than listen. And then you've got to act on what you hear. And sometimes it's not that easy, and sometimes you actually don't want to act on what you hear. So then it comes with the explanation of the why we have or the why we haven't, and I think that creates a real trust organisationally. And if you can get the people speaking openly and sharing a view courageously, then you create that psychological safety where improvement follows. What kind of resistance have you faced to that? I mean, I guess the fire service has a reputation for being quite macho. Yeah, and it's, I hope that's significantly different than that. There's a lot more female firefighters in Merseyside today than there was when I joined. But resistance, I suppose, if I kind of reflect back on our cultural journey and our engagement journey, I remember back in 2014, I was the deputy chief at that time, and I wanted to introduce our first staff engagement survey. And I remember vividly a couple of people who were part of the strategic team, in effect said, what would you want to do that for? Because you know what people will say. And we've come out of quite a turbulent period of industrial action. And I knew it would be difficult, but we did that anyway. And they were right, by the way, because it was a pretty poor outcome from a staff engagement. I think the staff engagement levels were about 43% at the time. So they were right. But the staff engagement surveys now, back in 2022, moved us from competitive disadvantage to competitive advantage. It's now 88%. And if you ask people insight around that, they would say that was unprecedented. But you've got to be brave and you've got to be courageous. And interestingly, for those in the audience, the people who had resistance over taking that step don't work for me no more, right? Because the reality is, if you are not going to open yourself up to some kind of criticism, then you're never going to improve. So. Yeah. We'll open it out to the audience, but just one more question for you, Bill. How do you end the vicious cycle of patient safety failures, inquiries and recommendations? I mean, as a journalist, it feels like you can set your watch with these scandals. Like there's one every few months. And will we get to a time where they stop?
Yes, or I wouldn't be doing what I'm doing at the minute. I believe that we can. I think that when you assemble a panel to do a major investigation, like the East Kent one in my most recent experience, it's very tempting to want to set the world to rights. And you want to do that by making a whole series of very detailed operational recommendations. And I think they all miss the point. We've had hundreds and hundreds of recommendations. I mean, starting off with Mid Staffordshire, which I think had over 200 recommendations. I mean, it's never going to get to the root of the problem if that's what you're doing. I think we have to learn to raise our gaze a little bit above the detailed operational level and say what's wrong with the culture here that's making these things keep happening, and what's wrong with a culture that means that every time we rely on a group of parents, in the case of maternity services, telling us that we've got a problem with a service that they knew about and we didn't. But I believe that we can do that if we start to look at these quite difficult fundamental issues about compassion and about team working and about listening to families.
Thank you. Okay, do we have any questions in the auditorium? Put your hand up if you want to ask a question. My eyesight's not the best. Is there anyone with a hand up? Can you see anyone? I'll carry on. Okay, if you each could change one thing about the NHS and also stop one thing happening in the NHS, what would it be? Buki.
I think for me, I'd stop treating what is essentially a complex healthcare environment that involves people as if it were a linear process. I think for me it's about learning and helping people feel safe to really raise and report issues without fear of being blamed. And I think for me there's a difference between blame and being accountable and learning. But what I'm saying is, for us to be able to at least learn from errors, we need to create an environment that staff will know that they will be listened to, their concerns will be acted on, and then we can improve.
So that's one thing you'd introduce. What about something you'd stop?
No, that's one thing I'd stop.
You'd stop, okay.
One thing I'd introduce would be I think we need to embrace digital in terms of patient safety to help us monitor, to help us make things smoother and easier. So I would really encourage that digital aspect for patient safety. That would be one thing I'd introduce.
Henrietta?
So the thing that I would suggest that we need to stop to address is the epistemic injustice that exists, which is an imbalance of power between those with the jargon, the status, and the language, which means that they stop us from listening to patients and families, and also to staff who maybe have a lower down in the hierarchy. That takes removing power from people, and they resist that incredibly. But I think if we did do that, it would make an enormous difference to that escalation of concerns and how we respond to it. And the thing that I would introduce, as I'm sure is no surprise to you, would be the patient safety principles as a method for doing that. A method that we can use as a simple way of considering the patient's perspective from all those tough decisions that we're having to make. Those decisions at the ward, at the clinic, in the board, in the commissioning organisations, and all the way through into the national bodies. But until we have that big conversation about listening to patients and families as well as to our colleagues and acting on those, we will get in that same cycle of scandal, cover-up, inquiry. And that is one that we have to stop, because it's a national disgrace.
Thank you. Phil? I know it's not your area, the NHS, but...
No, but there's certainly some synergies. So what would I stop? I would stop talking down the NHS. Sometimes we can kind of have a negative perspective on things as employees as well as kind of users of the NHS. And positivity is so much more effective in making change than negativity. But that said, I would stop making excuses and get some stuff done.
Yeah. Bill, I'm not going to ask you that question because you had seven very particular pieces of advice.
I can add one if you want.
Go on, add one. Go on.
I really want to stop reputation management being the first response of health service bodies and other bodies. We need a proper response when something has gone wrong that doesn't involve denial and deflection and cover-up. And all too often, that's the response. It's not just an NHS problem, but boy, is it an important part of the response.
Is that to do with lawyers, PR people, or what's it about?
I think it's a natural instinct of any organisation that feels itself to be being challenged. Everybody reaches for this idea that we must protect our reputation and present ourselves in the best light. And I think the lawyers are part of the issue, but I think they're an excuse. The lawyers take their instructions from you, the client, and there's a bit of a sort of conspiracy of, we want you to tell us to keep stum about everything on the one hand, and yes, okay, you have to keep stum about everything on the other. It's a conspiracy.
We've got a question here about racism. Henrietta is right, this person says, in saying that tackling racism is critical to patient safety, and you also raised it too. It's a big question, but how do you make the NHS anti-racist, if that's the correct term?
Well, the NHS Race and Health Observatory described themselves as excuse removers. And I think this is the issue, is that there are people who are blind to some of the issues that staff are facing. We have problems in terms of career progression, but we also have health inequalities which arise from the way that devices are manufactured, the way that research is published, not looking at the demographic data that is really important here. And when it comes to some of the attitudes that, particularly in maternity, that women and birthing people have experienced, is, you know, this is something which I think we really need to tackle head on. It's not something that we can try to just say, well, that was that one individual circumstance. There are a whole host of underlying factors to this. But, you know, we have a very diverse workforce. We have a very diverse population. And if we get it right for those who are in greatest need, we're not going to make it worse for everyone else. We're going to make it better for everybody.
Thank you very much. Buki, the most popular question on Slido at the moment is about culture change. And the person says, culture change can't always be measured on improvement graphs. How do we help improvement and seek assurance on culture without relying on performance metrics? I guess this relates to our next session with the Minister about to speak.
Interestingly, we were talking about that before we came on stage. It is quite a complex thing, and I think it means different things to different people. And we talked about measuring, actually, the culture of a place, which is absolutely difficult to do. But I wonder if there are things that we can do that tells us what it's like. So we've got listening. How well do you listen to your patients? How well do you listen to your staff? And I think for me, talking about the Minister to come, I think that would be a league table that I would sign up to, about how well we're listening to our patients and how well we're listening to our staff. Because for me, again, I know it's a cliche, but I found it to be real, certainly in my organisation, that when you value your people, and I mean staff as well as patients, when you look after your staff, then your staff will look after the patients, and of course you'll be an outstanding organisation.
Well, I mean, I guess your job relies to some degree on metrics. But how do you feel about them?
It does. They're essential, but I do think that as well as measuring process, which we're arguably quite good at in the health service, we also have to measure outcome, and we're very, very bad at measuring outcome in the health service. One of the things that we came up with after the East Kent report was we need an outcome measurement system that will systematically tell you ahead of the more obvious indicators that there's a problem with your service. And we're well on the way, thanks to the chairmanship of Dr. Idile Murdoch, to developing a very good statistical process control system that's based on actual meaningful outcome measures. And if we have those, then I don't have any problem with measuring the rest of it, provided we do it reasonably well. But the bottom line is we want to be interested in outcomes.
Phil, is there obsession with metrics in the fire service?
Yeah, a little. How you measure culture is a different one. I think you've got to speak to people. Sometimes not the people you would expect. I think that gives you a good gauge of what it feels like to work in an organisation. Whether you work on an admin desk or you clean a hospital, you know, they are the people I would ask about what it feels to work around here, how they feel as though they are treated in their role by other people. I think that gives you a strong indication. I know from a personal point of view, you know, sometimes it is about feel, and I wouldn't take that away with a bunch of metrics. I think you've got to be visible as leaders and managers in an organisation. I think you've got to ask the right question, but I think you've got to trust your gut a little bit. You know, I've worked in my organisation when the culture has been absolutely shocking, and I know what it feels like now, and it is a huge distance from what it was to where it is. I don't need the inspector to tell me that. I know it, but still you've got to kind of pursue it and ask and kind of get the views of staff and teams and the smallest people in your organisation maybe.
Henrietta, a related question, the final question for the session. These league tables, are they compassionate, and might they risk frustrating the mission for patient safety?
Well, I think what Bucky was saying earlier about, what is the league going to be measuring? If we're measuring the compassionate care that we deliver to our patients and their families, if we're measuring the way that we listen to patients and respond swiftly and compassionately when people raise concerns, but also the way that leaders, and I see leaders in this room, and I know from the network that I have of trust execs, that the experience you have is not always of being listened to and treated compassionately yourselves. So, I would be maybe a little bit controversial in saying that if we had a system of ranking that's one of the things that I think would be empower you to then empower your staff to deliver the kind of care and compassion and the outcomes for our patients.
Thank you. Having gone on about metrics, I'm now going to encourage all of you to leave some feedback on this session through Slido. Thank you to all the speakers for taking all those questions. The next session on our agenda is a keynote speech from the Secretary of State for Health and Social Care, Wes Streeting. As a reminder, you can submit your questions via slido.com and ask them in the audience through microphones. Thank you for your time. And as you make your way off, I'm going to introduce the Secretary of State for Health and Social Care, the Right Honourable Wes Streeting MP. Thank you.
Good morning. I'm really glad I caught the tail end of that conversation. That was really interesting. And it's great to be here with all of you today. I gather Julian warned you yesterday that I would be laying down some challenges. Well, actually, I've come to lay down some direction, not just to make the case for reform, which I've done before, but to spell out some of how we'll do it and what I need you to do with me for us to collectively succeed. When it comes to the condition of the NHS today, the Darzi diagnosis is clear. The NHS has not been able to meet its most important promises to patients since 2015. A&E waits are causing thousands of avoidable deaths. 50 years of progress on cardiovascular disease has gone into reverse. 345,000 people are waiting more than a year for mental health treatment. That's more than the entire population of Leicester. And as the performance of the NHS has deteriorated, so has the health of the nation. Adults are falling into ill health earlier in life, and children are less healthy today than a decade ago. ARA's conclusion was that the state of the health service is heartbreaking, and I'm yet to hear anyone seriously contest this analysis, which was entirely based on the data. Of course, that didn't mean my Conservative predecessor didn't try, but she was left resorting to pointing out Lord Darzi was shock horror, a Labour minister, in an attempt to discredit the author and his work, conveniently forgetting, impolitely I might add, forgetting he did work for Conservative-led governments too, not to mention 3 decades of experience as one of our country's top surgeons. It's not just the Conservatives, there are others who argue that pointing out the state of the service is demoralising for staff and risks deterring patients from accessing care. Well, in my experience, not just as a patient, but in the last 3 years, talking to frontline staff and NHS leaders, most people appreciate the honesty and recognise that the biggest barrier to patients accessing care is long waiting times. And as I've argued before, a culture that puts sparing political blushes or protecting the reputation of the NHS above protecting the interests of patients is one that stifles inconvenient truths being spoken to power, that silences whistleblowers, and that ultimately puts patient safety at risk. Now, in the last few years, I've come to know many of you in this room, and in the last 4 months, I've toured the country talking to leaders and frontline staff. So I think I know you well enough to know that you share my view that honesty is the best policy, that you agree with the Darzi diagnosis, and that you share my optimism that the NHS is broken but not beaten. Every day, there are outstanding episodes of care being delivered by dedicated people working with some of the best science in the world. As Ara put it, the NHS is in critical condition, but its vital signs are strong. Our collective challenge is to take the NHS from the worst crisis in its history, put it back on its feet, and make it fit for the future. The budget was important. The Chancellor gave us the investment we need to arrest the decline, begin fixing the foundations, and start turning the service around. The NHS was the standout winner. We're delivering the largest health capital budget since Labour was last in power and the biggest cash uplift in day-to-day spending of any government department. There have been two predictable reactions to this. The first says that the NHS is getting too much money, that this is a black hole that consumes ever-increasing amounts of taxpayers' cash, and that the NHS will complain that it's never enough. So right on cue, some NHS leaders popped up in the newspapers, aided and abetted by the health think tanks, to complain that this isn't enough. Well, one of the luxuries of leading a think tank is that you don't have to engage with the choices and trade-offs that government does. The Chancellor had to raise more than £40 billion to plug not just the £22 billion hole we walked into in July, but also to fix the foundations so that our economy and our public services can recover from years of mismanaged decline. When the Chancellor announced the settlement for my department, she joked about how unpopular it would make me around the cabinet table. And the truth is, at the cabinet meeting in which she set out the contents of her budget, I did feel uncomfortable. Not because I was worried about the opinions of the people in the room, because they support the NHS and the investment, but because I am worried about the jobs they have to do. As I look around the cabinet table, I see a Justice Secretary who inherited overflowing prisons, a Work and Pensions Secretary who inherited more than 4 million children living in poverty, a Defence Secretary charged with securing our nation at a time when there is a ground war in Europe, as well as constant and emerging threats of cyber warfare in a more dangerous and unpredictable world. So every penny of extra investment that goes into the NHS was a penny that didn't go towards child poverty reduction, or extra prison places, or bolstering our armed forces. And more than that, every penny that's spent on treating sickness is a penny that doesn't go on preventing illness. And you know as well as I do that around only 20% of the nation's health is affected by the NHS. The rest is dictated by the poverty we live in, the damp on our walls, the food we eat, the air we breathe, and so on. So you can't pretend to care about the social determinants of ill health if you only ever ask for more money for the NHS. So then, the argument goes, we must do both. And of course, that's right. But the choices and trade-offs aren't just about spending money, but raising it. The tax burden in this country is at record levels. We chose, rightly in my view, not to hit working people in their pay slips. The extra investment in the NHS, as well as other public services, meant asking employers and the wealthiest to pay more. And you'll have seen in the past few weeks that there are those who disagree with the Chancellor's decisions, and that's the nature of tough choices. But we stand by our decision to prioritise the health service. Healthy businesses depend on a healthy workforce, and a strong economy depends on a strong NHS. But if you want to know where the average taxpayer stands on NHS spending, it's quite straightforward. They welcome the investment, but they worry it won't be spent wisely. They agree with the central argument we made at the last general election, that investment must be matched with reform. We entered government with the public finances and the public services in a far worse state than they were when Labour last went from opposition to government. Tight fiscal constraints mean that reform needs to do a lot more heavy lifting. But even if we'd inherited the strong economy and public services we saw at the height of New Labour, we would still need to reform our public services, because we're standing in the foothills of a scientific and technological revolution that is changing the world around us. Citizens are used to choice, voice, ease and convenience at the touch of a button. We expect everything faster. Unless our public services are modernised to meet the needs of our people, they'll become increasingly redundant and irrelevant to people's lives, unable to meet their needs. The failure to reform the state to meet the needs of the people is one of the fertilisers of populism we see across liberal democracies. The other is a failure to ease the pain in their pockets. So we need to address both, with NHS reform that delivers better outcomes for patients and better value for taxpayers' money. By now, you'll be familiar with the three big shifts that will underpin our 10-year plan for health, from hospital to community, from analogue to digital, from sickness to prevention. These shifts are not radical new ideas, but delivering them truly would be. They're necessary to tackle the challenges of our growing ageing society, rising levels of chronic disease, and rising cost pressures, as well as to seize the opportunities of a scientific revolution in which AI, machine learning, genomics, and data offer us the chance to transform our system of healthcare to one that can not only diagnose earlier and more accurately and treat more quickly and effectively, but also predict and prevent illness. But we're not waiting for the 10-year plan in May to get cracking with reform. Over the last few years, I've regularly heard the criticism of the top-down nature of the NHS. It can be a difficult criticism for those at the top to hear. But for the last 4 months, I've found myself at the top of the system, at the peak of the mountain of accountability. And I not only recognise the criticism, I agree with it. The NHS in 2024 is more hierarchical than almost any other organisation I can think of. Even our armed forces, as the Messenger review argued, are less locked and centralised into command and control. Those of you who have studied the birth of the NHS will know that there were vigorous debates within the Attlee government about how the new NHS should be organised. Given the vital role that a strong state and central planning have played in Britain's success in the Second World War, it was perhaps inevitable that Nye Bevan's centralised model won the day, albeit with some concessions to the doctors to overcome opposition from the BMA. But Herbert Morrison and others in the Labour movement had argued strongly for a municipally based model with power and control exercised locally. Attlee and Bevan could scarcely have imagined in 1948 that the single-payer system they created would make the NHS ideally placed to seize the opportunities of data, genomics, AI, and machine learning. The N, the national, in NHS is important. It should be the guarantee that patients everywhere are treated according to the same values and the same standards. When we were last in government, we recognised that not everything could or should be run from the centre. New Labour's reform agenda created foundation trusts, increased patient choice, and used financial incentives to raise performance and increase transparency. In doing so, they oversaw dramatic falls in waiting times and increased public satisfaction to the highest levels on record. I really can't explain what happened in the next 14 years, but I hope that someone somewhere is writing a PhD on how it was that a party of the right, setting out to liberate the NHS, ended up with far more centralised control and far weaker public accountability. But the legacy of their botched reforms we are living with. It's been mismanaged decline and a confusion over who is supposed to be doing what in the system and an absence of any governance philosophy. The framework I'm setting out today is based on triple devolution, with power shifting out of the centre to ICBs, to providers, and crucially to patients. I want to lead an NHS where power is moved from the centre to the local and from the local to the citizen. Morrison meets Bevan. It starts with clarity. The centre should be deciding strategy, policy, and clear objectives for the system to deliver on behalf of patients. We should allocate resources against those objectives and provide the overall accountability framework for improving performance. We should ensure the same standards of care in every part of the country, and we should unlock the unrealised potential of the NHS as a single-payer model by making the NHS the best partner in the world for the development of new treatments and medical technology, and to make the most of our collective purchasing power to deliver value for money. And the centre should be smaller. As power flows from the centre over time, resources should flow with it. Otherwise, it will keep swamping local services with diktats and demands that distract them from the job of meeting patients' needs and improving the communities they serve. We need more doers and fewer checkers, and the centre needs to learn the words stop and or after years of start and more. Clear priorities mean a few, not 50 different targets, so the instructions coming out in the forthcoming NHS mandate and the following planning guidance will be short. I want to see waiting times cut, urgent and emergency care when people need it, and improved access to primary care. The shift from hospital to community needs to start now. Amanda set out yesterday that NHS England, not ICBs, will be responsible for managing performance of trusts. When I talk to ICB leaders, I hear mixed views about where they should be focusing their efforts. There is no uniformity and too much confusion. So let me be clear. I want to see local commissioning back and I want to see ICBs leading it. ICB chiefs, I'm talking directly to you. You will lead the transformation of care, the pioneers of reform. Your organisations will play a critical role in doing what we've never pulled off before, shifting the system left. I want ICBs to focus on their job as strategic commissioners and be responsible for one big thing, the development of a new neighbourhood health service. It will focus on building up community and primary care services with the explicit aim of keeping patients healthy and out of hospital, with care closer to home and in the home. All the evidence suggests that 1 in 4 patients in hospital should not be there, and that 1 in 5 emergency hospital admissions are preventable so long as earlier diagnosis takes place. So there's your challenge. We need to design services around people, particularly more than 15 million people with long-term conditions who are too often passed from pillar to post, from one service to another. Fragmentation needs to give way to integration, and that is the job of integrated care boards. That will leave providers, whether NHS Foundation trusts or regular trusts in mental health, community or acutes, to get on with the job of improving frontline services for patients, including restoring the 18-week waiting time standard. Over the past decade, provider freedoms have been curtailed. I view that as a retrograde step. Starting with the best performing trust, providers should be given greater freedom and flexibility to innovate, run community services, and manage their own house to meet the needs of their patients. The last Labour government had a philosophy of earned autonomy. I want to go further and faster than my predecessors did. Our long-term ambition is that all providers should enjoy the same freedoms as foundation trusts, so long as they deliver improved performance. And critically, those ICBs that perform best, particularly in developing neighbourhood health services, should also enjoy greater freedom and flexibility. We will no longer treat all providers and ICBs as if they are all performing equally, when you and I know it's a mixed ability class. We'll assess systems against a set of criteria and publish the results starting from next year. Those systems and providers that are in the middle of the pack will get support to improve, to bring them to where the best are now. Those ICBs and providers that are doing well will be rewarded with greater freedoms over how to spend their capital, with fewer ring fences, for example. Those that demonstrate the best financial management will get a greater share of capital allocation. We want to move to a system where freedom is the norm and central grip is the exception to challenge poor performance. So improving services for patients should be rewarded, and the quid pro quo is that there will be no more rewards for failure. The work you do couldn't be more serious. When you get it right, lives are saved. When you don't, the consequences can be tragic. If performance dips, I reserve the right to take those freedoms away. And for those judged to be persistently failing, we will act, going from 0 consequences for failure to 0 tolerance. Our new pay framework for very senior managers, which I know has been long awaited in the system, will be published ahead of the next financial year and will set out substantial reforms. It will drive consistency, increase transparency, and limit VSM pay inflation, whilst giving sufficient flexibility to attract talented candidates to the most challenging roles and providers. It will also ensure that those who are in charge of organisations that persistently fail to provide decent care or fail to keep a grip on their finances do not receive annual pay uplifts. Failure to have appropriate regard to the framework will be considered a governance issue and therefore be backed by the full range of regulatory levers at NHS England's disposal. Failing ICSs will not have access to capital flexibility, and neither will trusts, including foundation trusts that have the badge but don't meet the mark. Turnaround teams will be sent in to diagnose the problem and help fix the problem. Financial controls will be imposed if necessary, and where leadership is found lacking, they will be removed. Now, given the performance of politicians in recent years, you might think it's a bit rich for a politician to be stood here telling you about leadership. But there's one thing I'm sure of after the last 4 months. One person behind a desk in Whitehall cannot deliver the mammoth task ahead of us. Taking the NHS from the worst crisis in its history and making it fit for the future will require first-class leadership at every level of the system. The journey of reform is one I'm determined to take with you, not impose upon you. And that's where you can expect a break from the past, a grown-up, break from the past. No more manager bashing for manager bashing's sake. Lord Darcy's investigation into the NHS concluded, and I quote, that the problem is not too many managers, but too few with the right skills and capabilities. And let me tell you, that is not the most convenient conclusion for a politician to receive. I could be no more popular than announce the sacking of lots of managers. But that would not be the right thing to do. And I'm prepared to make an unpopular argument with the public about the value of good leaders. The NHS is one of the biggest organisations in the world. We should be competing with global businesses and public services to attract top talent. And for that, we need to attract and retain the best. So we will invest in you and support you. Yesterday, Amanda laid out our plans to develop a new NHS management and leadership framework with a single code of practice, set of competencies, and national curriculum to help develop essential leadership capabilities. And today I can announce that we're establishing a College of Executive and Clinical Leadership to help train and develop excellent NHS leaders. Non-clinical leaders should be working in lockstep with clinical leaders. And that's why I want this resource to be available to every type of leader in our NHS. And I've asked Sir Gordon Messenger to help us develop and attract the talent we need to develop our 10-year plan. The most important person in all of this is the patient. Since we launched the national conversation on the future of the NHS with the Prime Minister a few weeks ago, I've been struck by how loud the patient voice has been during the exercise. It's almost the inverse of my experience in my average working day. Popular and familiar ideas, like allowing patients to choose where and when to be treated, making it easier to rearrange appointments, and grouping tests and scans together in one visit to save time, rarely pass the lips of most of the people who walk through my door to say something to me. I said in opposition I would be the patient's shop steward. Now I'm in government, I'm here to be the patient's champion. They will be at the heart of the 10-year plan next year. Their priorities will be reflected in a new NHS mandate shortly, and when the elective recovery plan is published in the coming weeks, you'll see that greater choice and control is at the heart of it. We start from a low bar, and we're not going to change the experience overnight, but the direction is clear. Patients should be able to choose where we're treated and when. The ease and convenience with which we organise most of our lives and the best performing providers allow us to organise our healthcare should be available to everyone in every part of the country. That's why I welcome Amanda's announcement yesterday about the new ping and book service for breast and cervical cancer checks. Power to the patient is my mantra, and it needs to be yours too. Finally, right now I know that many of you are feeling bruised and battered. 14 years of austerity, a global pandemic, and no political direction has taken its toll on everyone working in the NHS and social care system. I know it won't be easy to turn the tide, but my message to you today is a message of hope. The Prime Minister pledged the biggest reimagining of our NHS since its birth, and it falls upon all our shoulders to deliver this, the jewel in the crown of this government's decade of national renewal. The challenge is huge, but the prize is enormous, and the change has begun. The package of reforms I've announced today is how we'll get more out of the NHS for what we put in. This is how we make sure the investment announced in the budget delivers real change for patients, and this can only be a team effort based on a shared national mission to recover and renew our National Health Service. You have dedicated your careers to public service, and I know that among you, I'm not alone in the scale of my ambition. To coin a phrase, we are in this together. The NHS is already living on borrowed time, and if a Labour government can't improve the NHS, then it simply won't survive. But if we get this right, we can look back on our time with pride and say we were the generation that took the NHS from the worst crisis in its history, got it back on its feet, and made it fit for the future. Many of you in this room have done it before. We can do it again. Thank you very much.
Thank you, Minister. Before I take questions from the audience, I've got a couple of questions for you. There have been league tables before and they were scrapped. How will these be different? And are they just a gimmick that won't tackle deep-seated, complex problems?
I would take that criticism if it was the only thing we were talking about today, and if it wasn't part of a much wider package of greater freedom, autonomy, freedom to innovate amongst high performers, and a whole range of support for the middle of the pack, and a recognition that for people in the most challenged systems, we're going to look at a range of contextual factors. I think if I think back over the last 20 years or so of our experience of healthcare in this country, and you look at the systems with the poorest performance, even when the NHS is performing at its best, tends to be the same areas. So I recognise in those parts of the country that there are wider systemic challenges that we need to be alive to, and which, frankly, the NHS is well equipped to understand. The regions are well resourced. My department knows where those challenges are, and we need to get the best leaders into those areas to help turn them around and to deal with some of the underlying factors. But when it comes to poor performance, and I know people have seen some of the headlines and bristled, I think it is really important that as we try and rebuild the NHS and rebuild public trust at the same time, that we're really honest and unequivocal about the guilty secret of poor performance amongst NHS senior leaders, which is it is entirely possible. Indeed, I have seen it happen, if I think about some of the people who've passed through my own trust, that someone who is known to be a poor performing senior leader is quietly brushed aside, sometimes with a golden goodbye, and then magically reincarnated somewhere else, leading some other poor trust. And that has got to stop. And to people who bristle at the headlines and think, oh my goodness, is this about attacking all managers? Absolutely not. It's about weeding out the rotten apples to make sure that the excellent leaders are not tarred with the same brush. And if people don't think that good leadership makes a difference in poor areas, come and visit my local trust, Barking, Havering and Redbridge. For years we were known as a troubled trust. We were in and out of special measures. I'm in polite company, it's before the watershed. I won't tell you what my constituents said about our local trust. In Matthew Traynor, we have an outstanding leader who has built a really strong team of clinical leaders right down to the front line, one of the fastest improving trusts in the country, and some of the work that his team are doing, empowered by his style of leadership, is some of the nationally leading work on things like busting through the backlog. So good leadership matters, transparency matters, and that accountability matters, especially when you think about the life and death public service that the NHS is. So I hope that today, people think we've got, you can challenge me because you're here, but I think we've got the balance right on the kind of accountability and performance management side, but also I hope I'm not just taking you with me, I hope I'm following the direction that you've set for me in terms of letting go of control from the centre, setting people free to innovate, to be great leaders, and providing the support to equip you to do that.
Thanks. We know there's a rising demand and long waits for mental health care. We also know there's a lack of robust data when it comes to mental health services compared to physical health services. What reassurance can you give the audience that these league tables won't ignore mental health yet again?
Well, it's an interesting question because people can't have it both ways. You can't complain about data transparency and then say we're not including everything you want included. I do think there's an issue about mental health weights and the spotlight we put on mental health, and I'd say the same about paediatrics, by the way. I can tell you on behalf of the Prime Minister, he was pretty stunned on a visit here in Liverpool to go to Alder Hey, meet some of the brilliant clinicians working there, but also some of the national clinical leaders in NHS England who were sharing their frustration that paediatric care is not given the spotlight and focus and attention that it deserves. So I think, and taking on board my own kind of self-restraint here, about not kind of imposing loads of targets and weighing down more and more instructions onto you, I think the conversation we're having now and the conversation we have in the coming weeks and months will be really important for boiling down the key metrics that we want to put in the spotlight to improve patient care and to give you clarity of direction from the centre, so you're not being pulled in a million different directions by different people at different levels of the system, because I recognise from talking to many leaders how frustrating and actually how counterproductive that has been. And
this brings us to probably the most common question on Slido. What about social care? Where does that fit into these league tables?
Well, look, social care is important in and of itself. It's a public service in its own right, and it's important for the freedom, dignity and independence of older and disabled people. It is also integral to the success of the NHS. and I recognise that social care has been the poor relation to the NHS. It goes back to what I said in my speech about choices and trade-offs, folks. There'll be lots of people at the moment who are looking at the NHS settlement and thinking, oh, there are going to be some choices for us in the system here, and that